Is there any data of using BV in earlier stage Hodgkin's now? I know it's not yet approved, but I hear some centers are doing it. Are you doing it in your center?
The use of brentuximab plus chemotherapy in the earlier stage Hodgkin's is being tested right now. I think many of us as providers treat Hodgkin's lymphoma would like to get rid of bleomycin given its toxicity. So it depends really on the results of these kind of trials and what will lead to in terms of separation of the curve and the response rate for these patients. We'll be able to use it. Right now, we're not using it in the earlier stage because there is no indication by FDA, but hopefully this will happen in the future and we can get rid of the bleomycin where toxicity is really harmful for these patients and annoying for the provider to manage that.
And also another question, because BV targets the CD30, is it necessary to test patients for CD30 expression prior to treating BV? And if it's so, what tests are used? Do you use any percentage positivity? Do you also include any genomic testing for further precision medicine or personalized medicine in patients with Hodgkin's disease?
The CD30 positivity prior using BV is important because we need to know if there's at least some positivity or not. In the classical Hodgkin's lymphoma, it's an easier task because it's invariably positive in a higher kind of percentage in this kind of population. As a matter of fact, if there is CD30 negativity, I would question the diagnosis and probably will review that again. So in that kind of population, it's sort of given that they have CD30 positivity. In the other population with the T-cell lymphoma, it's present in certain percentages, depends on the or the pathology of these kind of T-cell lymphomas. So we'd like to test that, and we'd like to basically know it's positive. I wouldn't use the lower percentage as a negative indicator for using it. I would actually use it even with lower percentage in the cutaneous T-cell lymphoma and peripheral T-cell lymphoma. Assessing CD30 is achieved by immunohistochemistry or flow cytometry. These are very good tests and give us the percentage that we want, especially with the flow cytometry in detecting the CD30. I think in the relapsed refractory situation, we can add the next generation sequencing, which might show other sort of target for treatment of these patients. As I mentioned at the beginning, the effectiveness of BV is dependent on its mechanism of action, and as I mentioned that there are multiple ways of looking at the mechanism of action, whether the intracellular entrance of the antibody with the chemotherapeutic agent in the cell, or the immune effect from having an antibody as such on the surface of the cell. So there are multiple ways of dealing with the tumor that way. The presence of the CD30 positivity or negativity is really might not be needed 100% in patients with clear disease like classical non-Hodgkin's lymphoma or cutaneous T-cell lymphoma. We'd like to see some positivity, even if it's not really high percentage. We test for it in any way to treat with BV. If I have somebody completely negative and basically having cutaneous T-cell lymphoma, I might use it as a trial, depending on the other mechanism of action that might not show a very high percentage of the CD30. There is also a limitation with these tests of false negative results that might be considered when you're treating patients with cutaneous T-cell lymphoma or peripheral T-cell lymphoma. In general, we like to test for the CD30 positivity. I would say the next generation sequencing in classical non-Hodgkin's lymphoma would be valuable in relapsed refractory, especially multiple relapse and refractoriness of the disease, in trying to figure out other sort of target for therapy that might open the door for more therapeutic agents to be used in this kind of patients. So it would be valuable in this kind of situation. I don't think it's right now it's showing its validity in the upfront testing, but eventually we'll see the effect in the relapsed refractory disease. I don't think all patients should undergo it in the frontline therapy, but all patients with multiple relapses of the disease would benefit from having next generation sequencing to try to find a target for treating this disease.